Dear friends, liebe Freunde, meine Grüße an euch alle. Thank you so much for inviting me to be with you in Vienna. The title of the Congress, Von himmelhoch jauchzend bis zu Tode betrübt, is perfectly in line with the ethical dilemmas that we are facing in the 21st century. Many of these dilemmas will also be addressed in the new 2020 CPR guidelines of the European Resuscitation Council. Our ultimate goal is to provide excellent evidence-based guidelines, including evidence-based ethical guidelines. Yes, the common ethical principles should be based on solid evidence whenever possible. But scientific evidence about ethical issues is limited, and today ethical topics are mostly absent in the agenda of ILCOR. Also, implementation of ethical guidelines will always be guided by local legislation, organization, and culture. Since the onset of the 21st century, we can observe major changes. Patients are changing. They are older, with more comorbidities, but they are better informed, and they are more multicultural. Medicine is changing. Organization of EMS, dispatch-assisted CPR, hypothermia, eCPR, and revascularization of heart and brain. But there is also a trend that medical practice becomes influenced by economic and commercial rules. And society is changing. Expectations are high and sometimes not supported by reality. And there are priorities and economic concerns. These changing conditions have also modified our interpretation and implementation of the traditional concepts autonomy, beneficence, non-maleficence, justice. And also our way of thinking about end of life has changed. In many European countries, there is now more freedom to participate in the debate about the wide spectrum of end of life: palliative care, palliative sedation, euthanasia, physician-assisted suicide, and suicide. Advanced directives and advanced care planning are reliable tools to protect patients' autonomy when properly used. But we should keep our eyes open, because they may also become a tool for health politics or even for commercial projects. The title of the Congress reflects also the bipolar conflicts between justice and selection, between autonomy and paternalism. Autonomy, yes, we all support it. The patient has the right to decide to accept or refuse a treatment, provided good information. And we must protect this right. But at the end, the patient will ask the expert, "Doctor, what would you recommend?" Therefore, I think that there is no antagonism, that there is no conflict, but that the solution is communication, confidence, honesty. In this Congress, you will also discuss the dilemma between expectations and reality. In the optimal scenario of a shockable rhythm, early CPR, early defibrillation, and early advanced care, some centers reported a good outcome as high as 40%. But on average, overall good outcome from out-of-hospital cardiac arrest remains low, with a 1-month survival between 7 and 15% only. But what is good outcome? We usually qualify CPC1 and CPC2 as good outcome. For CPC1, okay. But CPC2, is it also good? What is the opinion of the patient, of the survivor, of the family, of the society? We try very hard to improve survival, but we know that this has a price. The price of poor neurological outcome, but also the price of emotional and financial cost. Are we prepared to pay this price as a family, as a patient, and as a society? DNR, advanced directives, advanced care planning, TOR rules, and other rules for not starting and stopping. Most of these tools are mainly focusing on no CPR. But for me, CPR is in the first place a story about yes, a story about hope. If I would be hit by a sudden cardiac arrest, and if the scenario is favorable, my choice would be yes, please go for it. Yes, ready to go for a fast shock and good CPR, and keep me cool, and give me a couple of stents afterwards. I would be prepared to pay the price. Dear friends, I wish you a very successful Congress.